During diastole, we are no longer generating any pressure from the heart, but I mentioned that if you look at the aorta, leaving the heart here, and it's the same thing for the pulmonary trunk. This is what we're going to call a large elastic artery. And when the ventricles are squeezing and pushing, this thing is going to stretch out. It's going to kind of, and then when the ventricles are relaxing during diastole, you have the elasticity compress it back down. It can't, how come it can't go back into the heart?
The semilunar valves.
Right, we got the semilunar valves to make sure that the blood isn't going to go back into the heart, but it's going to continue propelling the blood towards the body. So this is what diastolic pressure is, right? We talked about this during the idea of isovolumetric contraction. Remember that? Isovolumetric contraction happened because you've got the diastolic pressure in here, and when the ventricles start squeezing, nothing happens until you overcome diastolic pressure and achieve ventricular ejection and have the blood finally leaving the ventricles and going into the aorta. So back to our other drawing. During diastole, the pressure is going to drop, but it's not dropping to zero because we have the pressure being generated by the propulsion of those large arteries squeezing. So down, 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 but then it's dropping. But then, oh my God, another heartbeat comes back up. But then, oh, diastole comes back down. Oh, another heartbeat comes back up. So it's going up and down and up and down and up and down. The peak is our systolic pressure. The trough is the diastolic pressure. Typically you write somebody's blood pressure as two numbers. This person here would be 120 millimeters of mercury over 80. So this person here would be 120 over 80 because during systolic, it goes as high as 120. During diastolic, it goes down as low as 80. So this is kind of a classic, and this is like a normal, I think now this is considered even like a little higher than you'd like, but this is considered kind of ballpark for a normal blood pressure. Once it gets like above 140 or up above like 90 or 95, you're starting to get into kind of hypertension and stuff. So questions about what we mean by when we write blood pressure this way. It's basically two numbers. One number that is the pressure during systole when the heart is actually squeezing, generating pressure. And then diastolic pressure is when the heart is relaxed and refilling, but those large arteries are continuing to propel the blood and keeping the blood pressure up. Like I mentioned, it's often useful to just use a single number for blood pressure, like an average number, like what I was using in lecture today. I was saying the mean arterial pressure, MAP. This is useful often in studies as well. You're trying to look at blood pressure versus as a dependent variable, and you wish you just had one number instead of having to mess with two numbers. So on average, what's their blood pressure? I don't want to deal with two numbers. You can't just average these because we spend more time down near diastolic than systolic. So mean arterial pressure is defined as it's going to be the diastolic. Yes, did I spaz? Diastolic plus 1/3 of the systolic minus diastolic. So it's basically this plus 1/3 of this distance. So it's right here. So somebody said, so it's going to be about 93 1/3, right? In this case, we have systolic minus diastolic is 40. 1/3 of 40 is 13 1/3. And 80 plus 13 1/3 would be like 93 1/3 millimeters of mercury, because I want to keep my units. So that is the basic way you do mean arterial pressure. This number here, systolic minus diastolic, which is again this distance here between the low and the high, we call this the pulse pressure. This is just systolic minus diastolic. And that's when you were feeling your pulse. That's what you were feeling. You're feeling it going from the lower to the higher, back down to the lower, back to the higher, back to the lower, back to the higher. That's why you're feeling that push against you, that change in force against the vessel, expanding the diameter that you feel. So pulse pressure. So we could also say mean arterial pressure is diastolic plus 1/3 of the pulse pressure. That's the same difference. All right, so there we've got the terminology out of the way. And now what we're going to do is let's talk about, you want to measure somebody's blood pressure. You would rather not put some sensor into their major arteries. That's bad. It would be nice if we had some way to measure someone's blood pressure without sticking probes into their arteries. And we have an awesome technique. We have the classic technique to measure your blood pressure, which we are going to now go into. The Oscultatory Method for the indirect assessment of blood pressure. So auscultatory, auscultate means to hear, to listen. So it's going to be using your ears, using a stethoscope in a particular way to make conclusions about what's happening, even though we're not actually inside the arteries. We have to also talk about a few ideas here. If I have a blood vessel and there is smooth blood flow through it, so smooth flow we also call laminar flow. If you have smooth flow, you don't really hear much. This is pretty much silent, right? If you have water running through a pipe, but it's not turbulent at all, it's actually, you don't really hear it. If you just like put your ear on your arm, you don't hear, like, even though the blood is going faster and slower and faster and slower and this and that, as long as it's pretty smooth, you don't hear much. If you constrict things, so the blood's coming in and it's going blah, 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 blah. Turbulent flow, the turbulent flow kind of And think about the rapids on a river or something, right? If you're just kind of by the creek is flowing, it's like, but then you hit the rapids and you just hear all the waterfalls and everything. So this turbulent flow is noisy. I do, if I have airflow coming out of my mouth, you don't really hear much. I'm breathing in and out. If I have a constriction of my lips, so there's turbulent flow, did you all hear that? So
yeah.
if I'm going, right? So you have to keep that in mind. If you can have the flow coming through the vessel, and if it's smooth, it's quiet. You can put a stethoscope on top of it, you won't hear anything. But if you have turbulent flow, which is going to happen when we're constricting the vessel with the blood pressure cuff, you actually can hear, they call it the sounds of Korotkoff. These are the sounds that you hear with your stethoscope when you are listening to the artery if it's been compressed and you have turbulent flow. So this is like, I should. So the artery's compressed, you get turbulent flow and it's noisy. So that's important to understand how this whole thing works. And so now I'll just show you the basic thing. I'll describe it, then we'll watch a little video, and then you're going to do a little quiz. So the basic idea is you're going to take somebody's arm. This is their brachial artery. Which we've seen from last class goes into the radial and ulnar and digital or whatever, but we're mainly worried about the the brachial artery. That's going to be our focus for this class. We are going to have a stethoscope, which we're going to put over here. The stethoscope is basically the tool we use for auscultating. It's the thing that you can hear quiet things. It's how you listen to the heartbeat. It's how you listen for the sounds of Korotkoff. The sound, the turbulent flow or smooth flow in an artery. And then we have the blood pressure cuff itself. Oh, hold on, I need to do a battery deal, power cord, so I don't lose you all. So let me try to draw this well here. So this is so much easier to show like in 3 dimensions, but we'll do our best here. So the basic idea here is you have this cuff, which you can wrap around the person's arm. It's got this rubber bladder inside. So as you pump it with air using this little squeeze deal, this is basically like a little rubber bulb. This is basically a little bulb. You pump the air and this thing starts squeezing tighter and tighter around the person's arm. And this gauge will tell you in millimeters of mercury how much pressure is this bladder pushing against your arm with. This whole deal, this is called a sphygmomanometer. You should know that name probably. So this is the sphygmomanometer. And again, you've got the blood pressure cuff, which will push. And again, because you're putting it around your arm, it's going to compress the brachial artery. We have the stethoscope on top of the brachial artery so we can hear what the flow sounds like in the brachial artery. Using the pump and the gauge, we can change how much pressure we're pushing down. There's this little needle valve here. And so what you can do, you have to open it when you pump in, but once you've got it pumped up high enough, you can close this off. And then if you want to let the air out, you can turn the little needle valve and bleed the air out. So this is the setup. So now I am going to just describe the, normally, again, we just have somebody in front of the room, but I'll describe this very briefly and then we'll watch a little video. And there's the brachial artery coming down. There's the blood pressure cuff. Again, with our little pump, little bulb to squeeze, and a little valve. And we also can see the pressure. We have our stethoscope. Kind of listening to what's going on. So the way you start this whole thing is you need to pump up this bladder high enough that you're going to completely block the blood flow through the brachial artery. How much pressure do I need to block the blood flow through the brachial artery?
More than 120?
Exactly. So this is going to have to be something greater. Greater than the systolic pressure.
I think
Right.
it's like 30 millimeters per mercury above the systolic pressure.
Right. So the thing is, you don't know what their systolic pressure is yet. So
Gotcha.
you need to get somewhere above it. So you have to kind of ballpark it. So usually if you shoot for something like 160 or something, you're probably going to be okay. If you still are going to hear sounds, you might have to go higher. In general, you don't want to go too high because it's going to be uncomfortable. So you pump up above the systolic pressure. And what are you going to hear when you're listening here?
First, nothing.
It's going to be silence. Why is it going to be silence?
Because you blocked the brachial artery.
Exactly. You've blocked the brachial artery, so there's no blood flow. So as we start this whole thing, we've pumped it up above systolic, I don't know, somewhere around 160 millimeters of mercury or so. At this point, you don't want to linger here because you are now basically, you've put a tourniquet on your person. And the longer they wait like this, the more and more uncomfortable it's going to be getting, having a complete lack of blood flow to their arm. So what you're going to do is you turn this little needle valve. So you're going to start bleeding the air out of the cuff. And we're going to see the little gauge is going to start going down, because as the pressure in the cuff goes down, the gauge goes down. What's going to happen as more and more air leaves the cuff and the pressure in the cuff gets lower and lower?
The pulse will return.
All of a sudden, the blood will be able to fight and get underneath and get out the other side. And what pressure are we going to first having blood coming through, be able to run the gauntlet here?
Systolic pressure.
The systolic.
Yeah, the systolic. As long as the cuff is greater than systolic, the blood never wins, right? If your blood pressure, the highest your blood pressure gets to, let's say your blood pressure is 120/80, if the cuff is higher than 120, the blood hits a roadblock. It can't make it out the other side. As soon as the cuff gets below 120, all of a sudden it's going to start, I'm making it through, I'm making it through. It's not going to be kind of a nice smooth flow, but it's managing to kind of get underneath and get out to the other side. That's when you're going to start hearing the sounds of choric cough. So as long as the pressure was above systolic, we were in silence because no blood could fly through. But as soon as the cuff goes a little below systolic pressure, the blood will start managing to go through, and we'll hear the sounds of choric cough because the artery's compressed. The blood's having trouble, it's turbulent, but you can hear it. So that's the first thing you're listening for. You're listening for, when do I start to hear? And it sounds kind of like a tapping sound. So this person's like, oh my God, I'm hearing this tapping sound. And then he uses his eyes or her eyes or whoever, boom, 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 looking at this thing here and saying, what pressure was it at when I started hearing that tapping sound? And you note it or write it down. And that is going to be the systolic pressure, like that boundary where it goes from silence to starting to hear the sounds of choric cough. And then obviously we keep letting the air out because we do not want to keep them uncomfortable here. And as we keep letting the air out, and then the sounds disappear. What does that mean when those sounds disappear?
Diastolic pressure.
Yeah, so remember we talked about the idea of silent laminar flow. This means that the artery is not compressed at all. That means that the lowest pressure that is inside here is still bigger than the pressure outside. So there's no compression. We're not squishing this thing at all because, if we're 120/80, as long as it's less than 80 out here, then the vessel is not compressed at all and it's going to be silent. If it is over 80 out here, then we're doing some compression. You'll hear the sounds of Korotkoff. If it's over 120, you won't hear anything because you'll completely squish this closed. So, so this you're going to record as the diastolic. Again, this is, my picture here. This guy is again, or taking a look. Oh, the sounds just stopped. I'm going to look again and see what was the pressure when the sounds stopped. So when you're thinking about this during our lab today and during your lab exam as well, you need to know both the mechanics. How do you measure a blood pressure? What's the actual procedure? But then you also have to understand the theory, the idea that, again, you're pumping up first above systolic, blocking all blood flow. That's why it's silent. Bleeding the air out. As soon as you hear the sounds, that means blood is flowing through. That means we must be below systolic. But as long as you keep hearing sounds, you're also above diastolic because there's still some compression. If there wasn't compression, it would be silent. So you keep letting it out. And as soon as you let it out enough that there's no more sounds at all, then you know you've dropped below diastolic. Any questions about any of this? In terms of the pure mechanics, I would also say, you can't go as you're bleeding the air out, you can't go too fast because then you're going to miss the pressures when the interesting things happen. But you don't go too slow because then you're going to cause a severe discomfort to your subject. So you let it go like a few millimeters of mercury a second. You have to be, again, when you're doing it for real, you'll get a feel for it. You adjust the rate by, the little needle valve on the blood pressure cuff. You can just screw it in a little tighter or a little looser, and it will bleed the air out a little faster or a little slower. So you can adjust that. If things are going too slow and you're realizing, oh God, I'm gonna make my person hurt, you can speed it up and it'll start coming out. If it's going down too fast, it's like, oh, I'm gonna miss it. I better slow it down. You can tighten it up a little bit. So any questions about all of this?
Yeah, could you go over the like when you stop hearing the sounds for diastolic? Can you just explain that one more time?
So kind of back to this picture. So compressed, as long as the artery is compressed like this, you'll hear this turbulent flow. So as long as there's some pressure on the outside that's greater than the pressure on the inside, there'll be this compression and there'll be the sounds of Korotkoff, the sounds of turbulent flow. When you finally are in a situation where the pressure outside is less than the lowest pressure inside, then we're in this smooth laminar flow. So let's say our blood pressure is 120 over 80. If the pressure outside is still greater than 80, there'll be some compression and we'll hear the sounds. Once the pressure outside here is now less than 80, there is no compression on the vessel anymore. And now we're in this silent laminar flow again. So does that make it clearer?
Yeah, that does.
Okay. All right, so let's move now. I'm gonna go into share screen. Modules. Okay, so this thing here, this was just as we part of the summer, we had to do this more formal thing, which I just thought was ridiculous. But orientation page is just to, orientation page. This very page you are reading. Yeah, I was getting snarky by the end of this all. So you can ignore this. Like I said, you can just look at the module from module view and get a sense of what the module is about. This is just the pages from the PDF. Okay. This is better so you can watch somebody actually doing it, which is good.
This video was created by the Ohio Academy of Family Physicians to demonstrate proper technique for measuring blood pressure in an office setting. About 1 in 3 American adults has hypertension. The American Heart Association estimates the total costs associated with high blood pressure to exceed $40 billion annually. Measurement of blood pressure is used in screening for hypertension and for monitoring the effectiveness of treatment for patients with a diagnosis of hypertension. In the outpatient setting, blood pressure is measured indirectly. It is important to use proper techniques so that readings are consistent and reliable. The 2014 evidence-based guideline for the management of high blood pressure in adults report from the panel members appointed to the 8th Joint National Committee, also known as JNC8, guides current treatment of hypertension. According to JNC8, patients 60 and older who do not have diabetes or kidney disease, taking a manual reading of indirect blood pressure requires a stethoscope and a sphygmomanometer.
Here we go. All right, now we're in. I was trying to get past all that. You can use a lot of times in a clinical setting, they have these automatic machines, but they don't always. And you should be able to know how to do it manually. So it is important. It's not just, well, nobody ever does this anymore. You just like use a machine. You should know how to do this.
The stethoscope used should have tubing long enough to allow the clinician to view the manometer while listening to carot cough sounds. The bell of the stethoscope should be used as it permits better auscultation of carot cough sounds. A sphygmomanometer consists of a blood pressure cuff containing a distensible bladder, a rubber bulb with an adjustable valve, and a flexible tubing. The tube connects to a manometer which measures the pressure within the cuff. Each part of the sphygmomanometer should be examined on a regular basis to be sure that it is functioning correctly. The needle on an aneroid manometer should rest at 0 before and after each blood pressure measurement. Aneroid manometers should have calibration performed at least every 6 months. Blood pressure readings should be done when the patient is in a resting state. The patient should be seated for 5 minutes prior to checking a blood pressure so that the reading is not artificially elevated due to the exertion of walking to the room. The arm should be bare to the shoulder. A study looking at the effect of taking blood pressure through clothing showed little average change, but found that in patients with hypertension, there can be individual differences of plus or minus 20 millimeters of mercury or more when compared with measurements on bare skin. The patient must be correctly positioned to accurately measure blood pressure. The patient needs to have legs uncrossed and feet resting on a firm surface. The patient's back and legs should be supported by the chair. The manometer should be at eye level of the care team member. The patient's arm should be supported at heart level. A common error in taking blood pressure is the use of an improperly fitted cuff. The appropriate cuff size is determined by the circumference of the arm at the midpoint between the olecranon process and the acromion process. The cuff will have the size range listed in centimeters. Once the correct cuff is selected, proper fit is verified using the index line that runs perpendicular to the length of the cuff and a range line that runs parallel to the length of the cuff.
Right. I mean, most people use a normal one, but in our lab, we actually have larger ones, medium ones, and small ones. And if you don't pay attention, you will get improper readings. If you have somebody whose arms are too large and you use a regular size cuff, you're going to get readings that are too high. So you do have to pay attention to the proper cuff size.
When a cuff fits appropriately, the inflatable bladder should cover about 80% of the circumference of the patient's arm. Using a cuff that is too short and narrow results in erroneously high blood pressure measurement. When a cuff is too large, blood pressure measurements will be erroneously low. The cuff should be applied 2 centimeters above the crease of the elbow. It should fit snugly but still allow 2 finger widths under the cuff. When the cuff is in place on the upper arm, the index line should fall within the range line. Next, find the brachial artery. which is palpable about 4 centimeters from the medial epicondyle on the anterior surface of the elbow. Place the stethoscope lightly against the skin over the brachial artery, being sure that the pressure is appropriate for good sound transmission. Make sure that the blood pressure cuff and clothing do not touch the stethoscope. Inflating the cuff to an arbitrary level will often lead to overinflation, which can be uncomfortable for the patient. Determining the pulse obliteration pressure will avoid overinflation. Rapidly inflate the cuff to 80 millimeters of mercury while palpating the radial artery pulse. Continue to inflate in 10 millimeter of mercury increments until the pulse disappears. Then deflate the cuff at a rate of 2 millimeters of mercury per second, noting the pulse obliteration pressure where the pulse reappears. You are now ready to measure the patient's blood pressure. Inflate the cuff to 20 to 30 millimeters of mercury above the pulse obliteration pressure. Then deflate the cuff at a rate of approximately 2 millimeters of mercury per second while listening with the stethoscope for carot coughs.
So I should mention, so I don't do the pulse obliteration pressure, but you could if you want. But one thing people do get confused, if you're looking at the manometer, at the pressure gauge, you can see it start to do these little like pulses. And people start thinking those mean something and they don't. This is really about what you hear. So when you're seeing the little needles starting to pulse like that, it's not what you are paying attention to. It's irrelevant. The time you start to pay attention is when you hear the sounds begin. So make sure, again, because you can see as she's starting here, she has not hit systolic pressure, but we can already see that the changes of pressure above the cuff are actually causing these little undulations.
Approximately 2 millimeters of mercury per second while listening with the stethoscope for carot cough sounds. As the pressure in the cuff is decreased, blood flow in the brachial artery increases, which creates turbulence and generates carot cough sounds. Phase 1 carot cough sounds are clear tapping sounds that coincide with reappearance of a palpable radial or brachial pulse. Systolic blood pressure is determined by the onset of phase 1 sounds. Phase 2 and 3 sounds are of no clinical significance and are described as softer and longer, then crisper and louder. Phase 4 sounds become muffled and softer as the pressure measurement approaches the diastolic pressure, usually within 10 millimeters of mercury of true diastolic pressure. Phase 5 sound is not a sound, but rather is the level at which sounds disappear. The diastolic blood pressure is measured at the start of phase 5. To ensure that diastole has been...
That's just a big fancy way of saying, note what time the sound stops. So
reached, the cuff pressure should continue to be slowly deflated for an additional 10 millimeters of mercury beyond the 5th carot cough sound. The blood pressure should be measured at least twice, waiting 1 minute between readings, then recording the average of the two measurements. In the following example, please listen for the various phases of the carot cough sounds while you observe the reading on the manometer. An auscultatory gap is defined as the intermittent disappearance of the initial carot cough sounds after their first appearance. This phenomenon can lead to underestimation of systolic blood pressure. Obtaining the pulse obliteration pressure can be helpful in avoiding incorrect measurement. Certain conditions, such as cardiac arrhythmias, may complicate blood pressure measurement or interpretation. In these circumstances, decreasing the rate of deflation and averaging several readings may improve accuracy. Observer bias is the most common error that occurs in blood pressure measurements. It occurs because practitioners often show digit preference or round off the terminal digit. When two people use the same correct technique for measuring blood pressure, there should be little variation in the reading they obtain. By following the process demonstrated in this video, you will be able to correctly measure the blood pressure of your patients. Getting accurate measurements is crucial for your care team and your patient because blood pressure data is used to classify patients, to stratify their cardiovascular risk, and to monitor the effects of treatment.
All right, so are there questions? This shows a little more on a practical level what it looks like. The next thing you're going to do let me hopefully, so there's another video you can watch later that's basically the same basic idea, but there's no reason for us to do it together right now. Okay, blood pressure simulations. So this is this thing that is a little flash animation thing. Flash, which will only exist till the end of 2020. So I have to figure out something else to do with next semester. But you guys will be the last people ever to use this simulation. So I'll show you what it looks like, but I also want you to see as well. On the next page, there's a little blood pressure quiz where you take a quiz and you're going to answer questions about what the actual values you found during the flash animation. So have a piece of paper as you're doing the simulations. So if we go back to these simulations, I'll show you what they look like. I need to, hold on, I need to unblock this. Dagnabbit. Extensions probably. No, it's not. Where is it? Oh, maybe it's apps. No, I apologize. This is settings. Dagnabbit. Dagnabbit. Wow, flash and edge. Open Edge on the top, click the icon, click settings near the bottom of the menu that appears. Click view advanced settings under the advanced settings. Are there advanced settings?
Professor, when you clicked on it, in like the search bar, like a little, maybe go back to where you tried to open it one more time, because something popped up like in the search bar. Yeah, with that little red X on it.
Oh,
And
oh,
then
there it is. Okay, so this is what you got to do. Thank you so much. So I'm going to,
manage, maybe manage, and then
yeah, I'm going to manage, and I'm going to say, there we go. Okay, so now I'm going to go back and refresh this. Let's do this again. No, you little.
I think you have to press the allow instead of the, like what, I think what you did was just, oh, you got it.
You got it. So here, this is what you're going to be doing. And so, you know, there you can look the introduction, the concepts, the positioning, but the main thing I want you to do here, you know, here you can actually read about, you know, who was N.S. Korotkov, if you're curious, but the simulations. So the simulation, there's 3 simulations. And when you click on like simulation 1, you know, you inflate and then you let the air out. And then you'll start hearing sounds, and you'll have to look at the sphygmomanometer, look at there, and you'll notice when the sounds start, when they stop. And for the 3 different simulations, you are going to do the same thing, and you are going to record what was this fake person's, virtual person's blood pressure, and there will be a quiz that you then go into, where you answer those questions as well as some other things about the blood pressure. So what I'm going to do, I'm going to throw you all into breakout rooms again, because I think it's more fun to do together. And what I would like you to do in your groups is go and do those simulations and record, figure out what are the blood pressures based on that auscultatory method in this kind of simulation. And then, kind of come to a consensus in your group. You can do the quizzes together, make sure you're all getting the same answers, make sure it all makes sense. And then we'll come back like in 20 minutes or however long it takes you to do this, and we will continue. The point of this lab is not just seeing how to get the blood pressure, which is an important part of it. Part of today's lab really is about making sure you understand the process of it. And
Mhm.
the other part is then like look at how actual physiological things affect your blood pressure. Now we have a tool, or if we were in person, we'd have a tool to have blood pressure as a dependent variable. Have them do something and let's measure their blood pressure. So now that we have everybody back, are there any last questions about the simulation or the process or anything? I want to make sure everybody's really clear on that. All right, so for the lab for today, there are basically 3 different things that we're looking at. And they all have the same basic kind of form. So in all of them are dependent variable. In everything that we're going to be doing, the dependent variables is going to be blood pressure, and it's going to be pulse rate. So in all the cases, we're going to be doing different things and then looking at how their blood pressure and pulse rate change. And we're also going to be looking at not just how does it change in the moment, but also kind of the recovery. Like how much does it change when you change some independent variable, and then how long does it take to get back to where it started? There's going to be like 3 challenges. There's going to be exercise. It's going to be pain. And there's nicotine. So these are going to be our 3 independent variables. One, we're going to have the person do exercise. We have this thing called the Harvard step test where they step up and down and up and down and up and down for 5 minutes and really get their muscles going. Pain, we're going to use what's called the cold pressor test. It's where you put your hand in ice water. It's very painful, but it won't actually cause actual tissue damage. So it's used a lot in scientific experiments where you want pain to be the independent variable. So we can see how pain is going to affect blood pressure and pulse rate. Nicotine, we have somebody smoke a cigarette. Used to be much easier. The last few years, it's been harder to find people in the lab to smoke, but we usually find them. So this is the overall idea of what the lab is about. And then in each case, each experiment is structured very similarly. So in each one, there's going to be a baseline reading. You have blood pressure and heart rate. Right, so if you want to see changes due to some independent variable, you got to know what is it before they experienced some challenge. And then there is some challenge, right? So then there's going to be some challenge. And again, it might be exercise. It might be pain. And again, the exercise is going to be this Harvard step test, which is basically stepping up and down for 5 minutes. Pain, This is what we call the cold pressor test. So basically put your hand in ice water. And nicotine, which is basically smoke a cigarette. 1 minute after, we're going to take blood pressure and heart rate. So after the exercise, they're going to do the exercise for 5 minutes. Then they're going to sit down and you're going to let them sit for 1 minute and take their blood pressure and heart rate. Or you're going to have them stick their hand in ice water. And actually this one, while they keep their hand in the ice water, after it's been in for 1 minute, you take their blood pressure and heart rate. Nicotine, you have them after they've done this baseline, you have them smoke a cigarette. And then they come in 1 minute after they're done smoking, they take their blood pressure and heart rate. So you get this initial change in their blood pressure and heart rate. And then at 2 minutes, you're also going to take the blood pressure and the heart rate. And at 3 minutes, you also take the blood pressure and the heart rate. So in each of these situations, you'll see kind of the initial change to blood pressure and heart rate, and also how it resolves. What do you think? What are people's kind of predictions? And you don't need to have a formal hypothesis for this one, but we should talk a little bit about what you expect. What are you going to expect to happen to the blood pressure and heart rate after they've just done 5 minutes of vigorous exercise?
To go up
It's going to go up. And why?
Epinephrine.
because the cardiac output increase, so heart rate increase,
And why is the cardiac output going to have to go up?
because your muscles need more oxygen,
Right.
So,
and so I think the thing,
more blood.
so, and that is true. Although the thing that's always funny or interesting, I think, to remember here is this is, you do 5 minutes and then you sit. Right. So when we're taking the blood pressure and heart rate, they actually are finished with the exercise. They are no longer using their muscles. So
Okay.
they've done this exercise, but now they're sitting down.
Okay.
What did we talk about? What is now going on? They are still going to need an increased cardiac output, an increased blood flow. But why is it that what are they doing in their body that's going to require that increased flow?
Oxygen debt.
Yeah, that oxygen debt. There's going to be dealing with oxygen debt.
Okay.
So, and indeed, though, we're going to expect the blood pressure, the heart rate to go up to increase the amount of flow to go and regenerate all those things. Because you need, again, about 11 liters of oxygen on top of your normal oxygen in order to recover from going into oxygen debt like that. So we have to bring in and deliver like 11 extra liters of oxygen, and that's going to require a big increase in our cardiovascular function. Obviously, as time goes on, you're going to expect the system to get back to normal. That we call recovery. You're going to have some initial increase in blood pressure and heart rate, and then you'll watch them come back. That one of the definitions people have of kind of cardiovascular fitness is this kind of thing, like how off of baseline do you have to go to actually deal with the stressor, and how fast are you back to normal after you've done with the stressor? So, when we talk about fitness, in your lab, there's a fitness index that's kind of taking a look at how high does the pulse rate go up and how long does it stay elevated for? you know, and it's kind of a rule of thumb of how efficient your cardiovascular system is. You know, the reality is it's not that great of a fitness index. There's much more sophisticated ways, like these things where they actually they're monitoring the amount of oxygen coming in and out and this and that. But for our lab, it's, you know, it's one way to get a ballpark for fitness. It's just a little formula that we have looking at kind of the heart rate. How far did it go up and how fast is it coming down? So that is going to be part of the lab. And again, we're going to look at this. We're going to be continuing this on Thursday, because right now I'm kind of describing this, but we need to obviously go deeper. Would you expect the systolic and the diastolic blood pressure to go up in the same way when we're dealing with this exercise?
No, I think systolic will be higher.
So why is that? So we're increasing our blood pressure because we want to increase the flow. So the systolic is going to increase the flow because that's the pressure that's causing the bulk movement of blood through your vessels. Right? Diastolic, though, that's actually pushing back against the heart, stopping you from actually ejecting blood. So if you're like increasing diastolic by much, you're actually making it so the heart can't actually push the blood out into the body. So when we look at our data, it's going to be interesting to look at the difference, the elevation in systolic blood pressure as a result of the exercise, which we can say is going to help increase the flow. Whereas looking at the diastolic, you know, that doesn't make sense to have that increase much, because if that increased, that's actually keeping the heart from ejecting. That's actually counterproductive. So we're going to look at that results on Wednesday, but kind of that'll be an interesting thing that we'll see in this experiment. 3 more minutes. Let's talk about pain. What do you expect pain to do to blood pressure and heart rate?
Raise.
Yeah, so this is one of the things I really like doing this lab. And part of the reason I really like doing it in person is most people are really convinced, obviously pain is going to really have to be increasing your blood pressure. That's just kind of this, you know, of course it's true. And like I mentioned in the very beginning of the semester, the reason we do experiments is because sometimes the things that are intuitively true aren't necessarily true. And unless you actually do an experiment and get the empirical evidence, you don't know what really is happening in the universe. So when we look at the data for this one, it's going to be really important to kind of look at what we see compared to what we expect. And I think it's, yeah, I really think this is an important one to pay attention to. And again, I don't want to get too far into it, other than it's probably not, the answer isn't as intuitive as you might think. Nicotine. Nicotine is a stimulant. It's going to like increase your heart rate. It's a vasoconstrictor. It constricts your blood vessels. What do we predict it's going to do to your blood pressure? Yeah, if you're vasoconstriction, that's increased blood pressure. You know, so we will take a look at that as well. But again, for today, you should just make sure you understand how taking what blood pressure is, how you take blood pressure. If Maria, if you need to stay after, I can try to help you click on that thing. But you should have that quiz finished. The rest of it, we're going to look at these 3 things in more detail on Thursday. I'm going to, again, our schedule is a work in progress. So, you know, I think this stuff is important enough that we should go over it in a kind of we should not, I don't want to rush this because this is important stuff. I want you to actually have time to sit with it and we can work with it. So we will, so I'll say to be continued.